Hello. Very soon indeed you are going to operate on a patient and remove an impacted molar. How successfully you will do that will depend on how well you have assessed the situation preoperatively. Now, some third molars are very easy and others are downright impossible, and it's knowing how to differentiate between them before you start that makes life easy and keeps your patient ultimately happy. How then do you determine this degree of difficulty? Basically, by a systematic approach. This series of 5 videos will, I hope, start you on the road to instinctive assessment. Obviously, before you start any surgical procedure, obtaining a thorough history and a good clinical examination is of primary importance. I'm not going to talk about these, but in the first video I shall deal with classification of third molar impaction based on radiographs. The OPT is a pretty useful view of both jaws and will certainly show the presence of impacted third molars, and to some extent their degree of impaction. But it's not as reliable as you need. So, use an intraoral periapical view as well, as this will give you the necessary detail. Historically, impacted third molars have come to be classified by their angulation. That is, the mesial-distal relationship between the long axis of the impacted mandibular third molar and the long axis of the second molar in both sagittal and buccolingual planes. Let's have a look at the sagittal plane first. 4 types of angulation are described. Here's the first. Here, the long axis of the third molar is parallel to that of the second molar, so the tooth is vertically impacted. In this case, the long axis of the third molar is at right angles to that of the second molar, and this is known as horizontal impaction. In the mesioangular impaction, the long axis of the third molar is tilted mesially towards the second molar. The 4th type is the distoangular impaction, and as you must suspect by now, the long axis of the third molar is tilted distally away from that of the second molar. Right, that was the sagittal plane. What of the buccolingual plane? 3 types of angulation occur. In the occlusal diagram, the long axis of the third molar is pointing lingually, so this is lingual version. When viewed on a periapical X-ray, this is seen as the occlusal surface of the crown coming towards you. That is, it is the nearest to the intraoral film. In the second type, or buccal version, the long axis of the third molar points buccally. On this periapical film, the appearance is that of the occlusal surface of the third molar turned away from the viewer. That is, farthest from the intraoral film. In both buccal and lingual versions, the tooth may also be seen sagittally to be vertically, horizontally, mesioangularly, or distoangularly impacted. This is just to make it more difficult. The 3rd type of angulation, you may be relieved to know, is very uncommon. It is known as transverse. It comes in 2 forms. The tooth can lie in a complete buccal version, or it can lie in a complete lingual version. This film shows an example of complete lingual transverse impaction. The whole occlusal surface of the crown is clearly defined, and the remainder of the tooth cannot be seen. So far we have dealt with the traditional method of classifying the types of third molar impaction. In the sagittal plane, there are 4 types: vertical, horizontal, mesioangular, and distoangular. In the buccolingual plane, there are 3 types seen: lingual version, buccal version, and rarely transverse. Remember that these can get together in an assortment of combinations. In the next presentation, we shall look at further factors that are of importance in assessment. See you again. Welcome to the second program in this series. I'm now going to deal with the third molar by looking at its personal anatomy. If we look at any tooth, its basic morphology is that it consists of a crown and a root or roots. The close inspection of the gross intrinsic anatomy of these will provide the basis for this part of the assessment. Let's look at the crown first. What is important here is size and shape. Why? Well, to try and answer that question, let's look at 2 mesioangularly impacted third molars. The first has a large multicusped crown. The second has a small crown of smoother outline. Which do you think is going to be easier to manage? It's bound to be the tooth with the smaller, well-rounded crown, since this will require less operative intervention to free it from its impaction. A third factor to consider when looking at the crown of the third molar is there any related pathology, either within the crown, such as caries, or around it, such as the size of the follicle space? Intracoronal caries will only be a problem when the tooth is partially erupted into the mouth. How great a problem it is will depend on its extent. This diagram shows a distoangularly impacted third molar with extensive carious destruction of the mesial half of the crown. In order to manipulate this tooth out of the socket, application of an elevator must be sought on a level adequately below the destruction, in order to encounter sound tooth substance. Thus, greater surgical exposure of the tooth is required. The size of the follicle surrounding the tooth is also important. In the diagram, no follicle is seen, so to achieve space around the crown, you are going to have to provide it. In this second diagram of another distoangularly impacted, partially erupted third molar, the distal portion of the crown is surrounded by what appears to be an enlarged follicular space. On a radiograph, this would appear as a radiolucent area. The extent of this space is such that the crown has been apparently freed from the bone, and the necessity for the creation of space around it by you is reduced. So, it seems to be easier. Now we should consider the morphology of the roots, and the first factor we need to consider is number. It's most important to look very carefully at the radiograph to determine the number of roots present, and it's essential not to be fooled. I'd like you to look at these X-rays. This one shows a developing third molar in mesioangular impaction. There are no roots as yet formed. This film shows a disto-angularly impacted third molar, this time with two roots, which appear to be fused. In the next film, we see that this third molar has two clearly defined roots. Now, look at this film. There are obviously two roots, one mesial and one distal. But if we look very carefully, we should see a third root passing on the lingual side of the roots. The presence of this extra root will be a major determining factor in how we tackle this particular third molar. Right, so much for number in our consideration of root morphology. I'm now going to look at size and shape. I'm going to deal with the factors of size and shape together and refer you back to some of the examples we've already looked at, and also show you some new ones. We've already established that this tooth has not started to develop roots, so size and shape is pretty irrelevant here. This one had two apparently fused roots, which are of average length and conical in shape. They are not going to present much difficulty in removal. This third molar root pattern is not so easy. To make things clearer, let's have a look at it in diagrammatic form. The two roots are separate, but curve sharply towards one another apically, forming their own personal anchor system. Each root will need to move along its own path of withdrawal to get it out intact, and that is not possible if the tooth remains whole. So, some form of vertical division of the crown will have to occur. So this tooth is presenting us with a greater problem. This one is also a problem. It's disto-angularly impacted, and the two long roots are somewhat excessively curved. But the curving is in a distal direction, so at least that is favourable. Let us again look at this in diagrammatic form. To remove this without fracturing those roots, successive distal division of the crown will be required. The first section removes the distal portion of the crown. An elevator is then applied mesially to rotate the tooth to this position. The crown is finally divided here. Mesial application of an elevator rotates the tooth upwards and backwards. This allows the tooth to be elevated out of the socket without damaging the roots. Here's another variation on size and shape. The disto-angularly impacted third molar here has two separate roots, which are not long, but their problem lies in their shape, which is excessively bulbous, as the greatest diameter exceeds that of the crown. Finally, in our examination of root morphology, we should look for any pathological changes occurring in the roots. An example of this is hypercementosis, and this relates well to the last case we have just looked at, since the roots have become excessively enlarged in all dimensions by successive layers of cement being laid down around the original root form. The difficulty of removal of this tooth is thus increased. This program has dealt with the morphology of the third molar itself. The things we have considered are the crown, its size, shape, and if any pathology is associated with it. Also, the morphological features of the roots that are important, such as the number, the size and shape, and whether they are affected by any pathological process. By analysing all these features, an overall picture of the problems presented by the tooth is beginning to emerge. In the next program, we shall see how the surrounding anatomy of the third molar influences the assessment. Stay with it. Hello again. In the first two programs, the types of possible impaction of the third molar were classified, and the third molar itself was anatomically assessed. In this program, the surrounding related structures are looked at, since they all influence the difficulty of the impaction. The structures under consideration are the adjacent teeth, any vital structures in close proximity to the third molar, and the bone surrounding them. You also need to make an assessment of any pathology occurring in relation to any of these structures. Let's look at the adjacent teeth first. In the case of an impacted third molar, we have only one tooth to consider, the second molar. What things should we be looking for? Anything which makes this tooth vulnerable to damage when removing the third molar. So, a large distal restoration with an overhanging margin, much as we see in this diagram, makes it susceptible to damage by displacing the amalgam with uncautious use of elevators, or by trying to forcibly remove the tooth along a path which it is reluctant to follow. Or, if there is distal caries, either untreated or recurrent beneath a restoration, which might cause fracture of the distal part of the crown during surgery. This again should be noted, and attempts made to avoid this happening. Do please remember before surgery starts to warn your patient if such possible problems exist with the second molar. Here's another problem. A disto-angularly impacted third molar, lying so close to the distal second molar root as to give the appearance of having no interdental bone. A suitable point of application of an elevator is made more difficult, and damage to the distal second molar root might occur. The morphology of the roots of the second molar is also of importance, since if, as in this case, they are conical, there is a real possibility of elevating this tooth along with the third molar. Similar displacement of the second molar might also occur in a situation such as this, when considerable alveolar bone has been lost around the second molar due to advanced periodontal disease. The importance of assessing the integrity of the crown and the form and security of the roots of the second molar cannot be stressed too strongly. It is not permissible to sacrifice an adjacent tooth in the quest to remove an impacted one. And that statement takes me naturally to vital structures in the vicinity of the impacted tooth. In the case of a mandibular third molar, this means the inferior alveolar neurovascular bundle. What we really need to know is just how close it is to the roots of the third molar, so that we can lessen the danger of possible damage. To assess the danger in which it lies, let's have a look at some examples of the variations in its relationship with the third molar roots. In this first diagrammatic representation of a periapical film, the roots of the unerupted third molar have not yet formed, and the inferior alveolar nerve lies some distance from it. Unless you are really not thinking of what you are doing, then you're very unlikely to harm the nerve surgically. In this case, the inferior alveolar nerve can be seen superimposed on the roots of the third molar, but in tracing the canal outline, no break in continuity, or narrowing, or deviation can be seen. From this, we may safely say that the nerve is lying lateral to the roots, but is not intimately related to them. What does it look like when there is a more intimate relationship? If we now follow the inferior alveolar nerve in this case, you will see that the upper margin is no longer continuous across the roots, and the lower margin is less well defined. This indicates grooving of the root by the nerve, and in the case of actual loss of canal outline in the upper margin, deep grooving. Damage to the nerve during manipulation of the tooth is therefore possible, and the patient must be warned of this preoperatively. A further possibility of the presentation on radiograph is shown in the next diagram. The inferior alveolar nerve has been deflected downwards by the mesial apex of the horizontally impacted third molar. The canal is also somewhat constricted at this point. This again illustrates the intimacy of relationship between the apex of the third molar root and the nerve, and any transmitted downward pressure on this apex will compress and hence damage the nerve. Finally, in the very rare occurrence when the nerve actually passes through the roots of the third molar, this next diagram shows the appearance you will see on the radiograph. The continuity of the canal outline is completely lost across the root apices of the third molar. If we were to look at this tooth buccolingually, we would see that the nerve is completely enclosed by the roots. This is not a case to be tackled by a beginner, as great skill is required to remove the tooth without injuring the nerve. Let me just repeat some of the signs to look for when assessing the proximity of the inferior alveolar nerve. They are: deviation of the canal by the root apices of the third molar, constriction of the nerve as it crosses the roots, and finally, loss of white lines, either upper or lower, that delineate the canal outline. If I have made you sufficiently fearful of damaging this nerve, I'm glad. The continued integrity of the inferior alveolar nerve is an essential part of good third molar surgery. Assess its relationship properly before you start, and use the knowledge to apply the correct surgical technique which the situation demands. And warn the patient preoperatively of the possibility of damage to the nerve. Finally, all these structures we have been considering are held in relationship to one another by bone. The quality of that bone, that is its density, varies between individuals, and sometimes indeed between different sides of the mandible. How easy is it to assess bone density on a radiograph? It's not always as reliable as you might like, because it depends a great deal on the clarity of the radiographic film. If this is perfect, then the trabeculation of the bone is probably accurate. By and large, a rule of thumb is useful. If the patient is young, the bone is probably elastic. If he is advancing in years, then it's probably not. Consideration of the structures surrounding the third molar are, therefore, essential before you embark on surgery. Look at the second molar. Ensure it's going to survive the surgical experience. Where is the inferior alveolar nerve? It may be closer than you think, so make sure. And don't assault bone. Young or old, it's really not kind. I hope you will join me again when we consider what really makes third molar surgery difficult. Bye. I'm beginning to admire your staying power. I really do want to take out a third molar. In the previous videos in this series, you remember, or at least I hope you do, we have discussed classification of impaction, the morphology of the third molar itself, and the anatomy of the surrounding related structures. What more, you think, can she possibly have to say about assessment? Actually, quite a bit more. We haven't yet examined all the factors which help in deciding how difficult the removal is going to be. Some are to be seen radiographically, and others can only be judged on clinical grounds. Let's have a look first at those additional radiographic features. They are the depth of impaction and the room, sagittally, that the third molar is occupying. Why is depth so important? I'm going to show you a pair of radiographs, and I'd like you to look at them carefully. They both show a disto-angularly impacted third molar of similar morphology. The adjacent anatomical structures are also similar, but the third molar on the right is considerably deeper in the bone than the one on the left. I think you will appreciate by now how much more surgical interference will be required to successfully remove the one on the right. Now, take a look at another pair of radiographs. These are two horizontally impacted third molars. The difference is again one of depth, with the one on the right being very much deeper. If you have limited experience of third molar surgery, then the one on the right is too deep for you. The depth at which the impacted tooth lies is thus of paramount importance in deciding how difficult it is going to be to remove. The other radiographic feature of great importance in assessment is the room between the ascending ramus of the mandible and the distal aspect of the second molar. Again, I am going to refer you to another pair of radiographs. Both radiographs are of mesioangularly impacted third molars. Their relationship with the second molar and the inferior alveolar nerve is more or less identical. Why, then, is the one on the right much more difficult than the one on the left? Its actual depth in relation to the occlusal plane of the second molar is the same as that on the left, but it looks deeper. Why? Because the distance between the anterior border of the ascending ramus and the distal surface of the second molar is so small. There is considerable lack of room in the case on the right, and that is what produces the difficulty. So, these two factors of depth of impaction and available room are of paramount consideration in assessing how difficult is the impaction. Up to this point, the only measure of assessment we have used has been radiographic findings. But unless we assess the patient clinically, we are missing some important guides as to how difficult the operation is likely to be. You must assess two additional factors before you start surgery. They are the extent of mandibular opening possible and the degree of compliance the patient is able to give you. Without an adequate level of either of these clinical factors, then the degree of difficulty increases as the extent of opening and degree of compliance diminishes. So if the patient can't open his mouth fully, or jumps out of the chair whenever you approach it, you may have a problem on your hands. Now, let's remind ourselves of all that we've learned to look for in making a preoperative assessment of the impacted third molar. And I'll put a summary of what I'm saying on the screen to help you remember it. First, the history and clinical examination. At this time, the degree of mandibular opening and the patient's compliance can be assessed. Next, we need to obtain appropriate radiographs, that is, an orthopantomogram or lateral oblique, and periapical views of the third molars. From these, we can proceed to a reasoned assessment, in which we can classify the angulation of the impaction, assess the depth and the room, describe the essential morphology of the third molar itself, and the anatomy of the adjacent structures. Only when all those features have been assessed can we work out the geometry of the surgical removal, and that is what we shall discuss in the last program of this series. Welcome to this, the last of the series on the third molar. The importance of assessment prior to surgery has been outlined in the 4 previous videos. Now, we must assemble all the pieces together to determine how surgically we need to approach the third molar and successfully remove it. You will remember from the last presentation the sequence of assessment we built up. I'll just run through it again. First, the history and clinical examination. At this time, the degree of mandibular opening and the patient's compliance can be assessed. Next, we need to obtain appropriate radiographs, that is, an orthopantomogram or lateral oblique, and periapical views of the third molars. From these, we can proceed to a reasoned assessment, in which we can classify the angulation of the impaction, assess the depth and the room, describe the essential morphology of the third molar itself, and the anatomy of the adjacent structures. Now, let's apply that to an actual case from the radiographic assessment. An orthopantomogram and periapical radiograph are on the screen, correctly named and dated. This is what they look like. The quality of the radiographs is uniformly good, and having checked when the films were taken, we know that they are recent, so we can proceed. If the quality were poor, or the radiographs were wildly out of date, then new radiographs would have to be obtained. So let's start by classifying the type of impaction. It's horizontal. Also, we can see that, since the crown of the third molar appears to be coming towards us, it's in lingual version. It's also quite deep, so we are going to need good access. And in this we're lucky, since the distance between the distal surface of the second molar crown and the ramus of the mandible is wide, so we have enough space. Now for the third molar itself. The crown is of a size similar to the second molar, is multicusped, and is intact. The follicle space surrounding it appears somewhat widened just below its mesial surface. The roots, of which there are two, are separate and curve towards each other apically. The mesial root is thinner than the distal, which is slightly bulbous. Both roots appear fully formed. Let's now have a look at the second molar. We see that it has a large occlusal amalgam restoration and has two separate roots which curve towards each other apically. The roots appear secure in the surrounding bone. The relationship between the occlusal surface of the third molar and the upper 2/3 of the distal root surface of the second molar appears very close. The other relationship of which we need to be aware is that of the inferior alveolar nerve. On the periapical, the outline of the canal is lost at the mesial root apex, and the lower third of the mesial root lies along the upper border of the canal, so the relationship here is very close. No gross abnormality can be seen within the bone of the mandible on the orthopantomogram, and this seems to be confirmed by the periapical. So, having considered all the points, how do we use them? Let's look at a diagram based on the periapical film and work out what we need to do to get this tooth out. The natural path of withdrawal of the third molar is impeded by the second molar, so the tooth must be taken upwards. But if we were to attempt to do so with the tooth intact, an enormous amount of bone would have to be removed. This is obviously not on, so to overcome this problem, the tooth must be sectioned. By sectioning vertically the crown from the roots, the crown can be elevated upwards. The roots can now be moved forward into the space previously occupied by the crown. But because of the apical curving of the roots and the bulbous distal root, they each have their own path of withdrawal. Also, because of the proximity of the inferior alveolar nerve against the mesial root, no downward force should be transmitted which might harm the nerve. So, to overcome this, the roots are sectioned from one another, and each moved forward and elevated out separately. To allow manipulation of the crown and roots, a point of application of an elevator must be chosen to facilitate movement in the required direction. For the crown, it is here. For the roots to come forward, there are 2 points, here and here. To be able to do all that, we must gain access, and that means bone removal. The diagram shows the area to be removed for exposure of the crown, for sectioning, and for the point of application of the elevator for its removal. Also, for the exposure of the roots distal to the vertical section, so that they may be sectioned and allow for the points of application of the elevator for their removal. At this stage, you can see now how large a surgical cavity you will have created, and hence with foresight can design your mucoperiosteal flap with this in mind. To enable the flap to lie on sound bone for as much of its length as possible and give adequate exposure of the surgical field, a design such as this may be adopted, where the posterior part of the incision lies along the external oblique ridge of the mandible and runs forward for about 1.5 centimeters to the distobuccal cusp of the second molar, since the third molar is unerupted. The advantage, indeed necessity, of placing it here will mean that you avoid the lingual neurovascular bundle lying on the medial side of the ascending ramus of the mandible. The anterior part of the incision now moves forwards and downwards from the distal aspect of the second molar to run as a curving incision to end around the anterior part of the second molar's mesial root. With your plan of the surgical technique established, you are now ready to prepare to remove the third molar. But before you dive in surgically, ask yourself this question: can I really get this tooth out and the patient on the way home within 30 minutes? If you can't, don't do it. If you can, good luck. With your plan of the surgical technique established, you are now ready to prepare to remove the third molar. But before you dive in surgically, ask yourself this question: can I really get this tooth out and the patient on the way home within 30 minutes? If you can't, don't do it. If you can, good luck. I hope that these programs will form the basis of your assessment. It is not possible to illustrate an example of each type of impaction, but for those of you who so wish, these programs are linked to a computer questionnaire on assessment and removal of impacted third molars. Why not try it?